and welcome everyone to the progress report. And let me present you my PhD thesis, which title is New Insights into the Application of Teledermatology. I am Katalin Martyin. I am a second-year PhD student at the Department of Dermatology, Venerology, and Dermato-Oncology. My supervisors are András Benvelgyi and Norbert Kiss, and my scientific methodology supervisor is Fanny Mesnerich. I currently have two ongoing projects. Both of them are systematic review and meta-analysis. My first project is comparing the diagnostic accuracy of teledermatology systems to face-to-face examination in the diagnosis of skin diseases through a systematic review and meta-analysis. So skin diseases affect a significant portion of the global population, with a shocking 3 billion people in the world lacking appropriate care worldwide. Access to dermatological care varies widely across regions, as seen in the number of dermatologists per 100,000 people. This number is 7 in Germany, 3.4 in the USA, and a mere 0.7 in Indonesia. The cost of a conventional in-person visit averages around $300, while teledermatology visits cost significantly less, approximately $40. In light of these factors, teledermatology stands out as a crucial tool in facilitating timely and affordable care, yet there is still some data missing regarding its reliability in the everyday practice. The most common method of teledermatology is the direct store and forward method, which means that the patient directly contacts the dermatologist, and this connection is separated by time and space. So our clinical question is whether teledermatology systems are as reliable as face-to-face examinations. We use the PICO framework. The population is patients with dermatological diseases. The intervention is diagnosis made with teledermatology systems, which is compared to the diagnosis made during face-to-face examination. And the outcome we are interested in is diagnostic accuracy. Our hypothesis is that teledermatology systems have non-inferior diagnostic accuracy to face-to-face examinations. We conducted a systematic search. Here you can see the flowchart of selection. After the selection process, we ended up with more than 150 eligible full texts. So let me present my results. First, we investigated the proportion of diagnostic agreement between teledermatology and in-person examination. On the slide, you can see two forest plots. The first one is a detailed one with all the articles listed, and the second one is the same basically, but it is for better comprehension. So the first analysis was conducted in the all skin conditions disease group, and we made a subgrouping based on the intervention method used. We looked at the proportion of diagnostic agreement, which means that if the diagnostic agreement is 0%, that means that there is a complete disagreement between the teledermatology and the in-person examination results, and if it's 100%, it means a complete agreement. So in this patient population, with the store and forward method, the diagnostic agreement was found to be 76%. With the real-time method, it was 74%, and with the hybrid method, it was 86%. These results show that there is a strong agreement between teledermatology examinations and in-person examinations, regardless of the method used. We conducted the same subgroup analysis in the skin cancer group, and we came to the same results. The store and forward in the store and forward group, the proportion was found to be 74%, and the real time was found to be 69%. As store and forward is the cheapest and most accessible method, it is really important to note that it is as accessible as reliable as the other methods when using teledermatology. So teledermatology can be made very accessible even in low resource settings. We made a different subgrouping based on the use of dermoscopy. Dermoscopy is in vivo method that allows the dermatologist to see in a non-invasive way the microstructures and the colors that are invisible to the naked eye. So in the all skin conditions group, the use of dermoscopy, with the use of dermoscopy, the diagnostic agreement was found to be 82%, and without dermoscopy, it was found to be 75%, which means that in this patient population, the use of dermoscopy is not necessary in every occasion. We also conducted the same subgrouping in the skin cancer group, and in the in the dermoscopy group, the diagnostic agreement was found to be 80%, and in case of the lesions diagnosed without dermoscopy, the agreement was found to be 67%. This means that in this patient group, the skin cancer patients may need teledermoscopy in order to be able to diagnose the lesions effectively. We also looked at some secondary outcomes. First, the time required to make a diagnosis. As you can see, it was 1 minute, so the doctors needed on average 1 minute to come to a diagnosis with teledermatology. And we also looked at patient satisfaction, and we only included patients who were highly satisfied with teledermatology, and the proportion of these patients is 82%, which means that the patients are very satisfied with these systems. So our study has some strengths and limitations. This is the first comprehensive meta-analysis investigating all types of teledermatological care. We work with a very large sample size, and we included data from all around the world, which makes our results more generalizable. It has also some limitations, which lie in the diverse study settings and the different reporting of outcomes. Based on our results, we can conclude that teledermatology is suitable for the remote diagnosis of all skin conditions. Store and forward and real-time are equally acceptable methods, and dermoscopy is only required in the diagnosis of skin cancer. The implication for practice would be the implementation of teledermatology to increase accessibility in patient care, thus because it can be used in lower resource settings too. Also, teledermatology is reliable even without a dermoscopy in case of general skin conditions, making it more accessible, for example, if the patient or the general practitioner does not have a dermoscope available. We also have some implication for research. Standardized reporting of outcomes are needed, and also reporting of true positive, true negative, false positive, and false negative values in order to be able to calculate the sensitivity and specificity more accurately. Here you can see the manuscript status. Our target journal is the Lancet Global Health. Here you can see the progress of my first project. I'm currently writing the manuscript. And let me jump to my second project, which is investigating the diagnostic accuracy of artificial intelligence systems in the diagnosis of skin diseases. One of the most discussed advancements of modern technologies at the moment is the use of artificial intelligence systems, and a very important aspect of AI-assisted decision-making is the use of these systems in primary care, as 65% of all patients with dermatological problems only consult their general practitioner, so they are in need for a real-time diagnostic support by these systems. Also, it may not only help the primary care, but also dermatologists, which is needed because of the shortage of the dermatologists in the world. Our aim is to determine the reliability of artificial intelligence systems and determine their role in the everyday practice. Our clinical question is whether artificial intelligence systems are suitable for making a diagnosis. We use the PERT framework. Our population is patients with suspected skin cancer. The index test is AI. The reference test is a gold standard diagnosis, which is either histopathology or diagnosis made by a dermatologist. And the diagnosis of interest is skin cancer. Our hypothesis is that artificial intelligence systems have non-inferior diagnostic accuracy to dermatologists. The clinical implication would be the implementation of artificial intelligence systems to improve the patient care. we are currently checking the feasibility of this project. So in summary, I have 2 ongoing projects, one regarding teledermatology and the second one regarding the use of AI in dermatology. Let me finish my presentation with the words of Marie Curie: "Nothing in life is to be feared, it is only to be understood." Thank you for your kind attention.
What devices were used in the store and forward systems? Was there heterogeneity across studies?
Yes, there was quite a bit of heterogeneity, and we also made a subgroup analysis based on the device used, which I couldn't show you because of the time limit. But we made 3 subgroups. One is smart devices, which contains a smartphone or a tablet, and the other one is video or a photo camera, so a digital camera, and the third one is other. But we could conclude based on our results that there is no significant difference based on the devices used, so either device is acceptable in the use of teledermatology.